بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. كل عام وأنتم بخير. هنكمل إن شاء الرحمن الكوفيد 19 lockdown webinars. Today we are starting webinar series spine for the non-spine. It is something to back to basics. We are happy to have Professor Dr. Ahmed Morsi as a co-chair for this series of webinars. And today we'll start by MRI of the spine, followed by degenerative disc disease pathophysiology and management. We hope that you can enjoy as a fruitful lectures, and we are happy to have your discussion and the questions after each lecture. Dr. Ahmed, kindly start.
Thank you, Dr. Mohammed. Good evening, everybody. I hope we can run through this topic easily and nicely. I will be talking about MRI of the spine. First, what is the MRI? To discriminate it from the X-rays and the CT scans, it is a non-ionizing imaging modality. The main idea depends upon the presence of high hydrogen atom content in most of the molecules of the body. The hydrogen atoms are highly sensitive to magnetic fields, and thus changing in the energy of the electrons could be controlled and sensed using the MRI machine. How does it work? First, a magnetic field is generated throughout the body, around the body. Then radio frequency pulses are generated at repeated pulses or patterns with different timings, with picking up of the echo or the return of this radio frequency pulse by the MRI machine. Every radio frequency pulse stimulated or imposed over the body causes the electrons of the hydrogen atom nuclei to be stimulated and thrown to higher energy shells or levels. When the radio frequency pulse stops, the electrons fall back to the original shells, releasing energy which is in return picked up by the coils of the MRI machine to be transferred into images using through the computer of the machine. This energy released after the cessation or the stoppage of the radio frequency pulse is called the resonance, and this is what gives us the image of the MRI. As I said, the concept depends on the presence of the hydrogen atoms with a single electron in the innermost shell around the nucleus. The high water content of the body with the high hydrogen atom content, and the variability of the water content among different tissues and among different pathological conditions, and our ability to control the sequence to contrast different tissues using different pulses, which in turn results in different resonance sequences which we pick up and process using the computer of the MRI machine. The common MRI sequence that we notice in the MRI films when we examine the MRI scan of a patient are the T1 weighted image, the T2 weighted image, the echo gradient sequence, the fat suppression or the stare sequence, and lastly the contrast enhancement. Of course, there are other sequences, but these are the most commonly ones we need to know in MRI of the spine. First, how to request a spinal MRI. When you send a patient to do an MRI, you should define the region you need, whether you need a frank region like the cervical, dorsal, or lumbar spine, or a junctional region like the cervical dorsal or the dorsolumbar or the lumbosacral. You should give a notion for the radiologist about the presence of any deformity, like a scoliotic deformity, for example. And if you need a specific sequence, like a contrast using gadolinium enhancement or a fat suppression or a stare image, you should notify in the request. And of course, you should give some data about the complaint of the patient and the possibility of a certain pathology like infection or a tumor or fracture or whatever. Next, how to read the spinal MRI. We should start with the sagittal cuts in the T2 weighted images. Then next to check the stair images or the fat suppression images, if any is available. Then check the axial T2 weighted images. Then finally the C1 weighted images, sagittal and axial images to confirm and to compare them to the corresponding ones, sagittal and axial of the T2 weighted images. Then lastly, the contrast gadolinium enhancement films. As regards different tissues appearance in the MRI, usually we should differentiate between the high flow blood and low flow blood tissues. The tissues with high fat content, like the subcutaneous tissues, the bone marrow on the T1 images, and the tissues with high water content, like synovial fluid in joints and facet joints, the intravertebral disc nucleus pulposus, the normal well-hydrated intact intravertebral disc, and other implants which are usually appearing dark on both T1 and T2 images, like the stainless steel, titanium, cobalt chrome, or other polymers like the PEEK. The concept behind the MRI device is the presence of the main magnet. Let's see here is the North Pole and the South Pole. This is the main magnet in which the patient is placed. Then the pulse emitter, which gives the radio frequency pulses, stimulating the hydrogen atom electrons to the higher energy levels. When this pulse stops, the electrons fall back to the original shells and release energy, which is picked up by the coil receiver. And finally, there may be interference from like the gadolinium enhancement injection or the control of the radio frequency pulses stimulated for the patient. This is the MRI device, the normal closed MRI. As we can see, there is a tube where the patient is placed. This is the main magnet, and this is the gradient coil. This is the gradient coil which cause stimulation for the patient, and other coils that pick up the returning pulse. This is the radio frequency coil. As we can see, the radio frequency coil here. Muhammad, is the arrow apparent on the screen?
No, yes, Ahmed, yes.
Okay, so this is the radio frequency. The arrow is apparent, it's moving.
Yes, we can see the cursor.
Okay, so this is the radio frequency coil that causes stimulation, gives the patient an impulse, and these are the gradient coils which pick up the returning resonance from the patient. As we can see, there are different coils in 3 axes, and there is a transceiver coil which moves along the part to be examined. If we need the lumbar spine, it will be located here. If we need the cervical spine or the brain, it is moved upwards, or actually the patient is moved along the table to center this purple colored transceiver coil around the area to be examined. This is the normal. This is a demonstration of the normal distribution or arrangement of the atoms, the electrons in the inner shell of the hydrogen atom. When a stimulus is applied, a radio frequency stimulus is applied using a magnetic field, all the atoms will be, or the electrons will be arranged into one direction, so that the energy received when the radio frequency pulse is out is usually collectible through a single transceiver coil. So, what are the common types of MRI? As we know, the static MRI that we all know, the contrast enhancement using the gadolinium, the dynamic MRI that is performed under motion, actually and unfortunately not present in every hospital or in every country, and the functional MRI, which usually tests some kind of metabolic activities, usually in the neural tissues. So what's the difference between the MRI and other imaging modalities? First, it is efficient at detecting soft tissue changes more than X-rays and more than CT scans. It is inferior at detecting cortical bone changes, where we can do in such instances the CT scan and X-ray. There is minimal or no risk of irradiation. As I said, it is a non-ionizing radiation. It is prone to interference and error according to the time used as a time of repetition and time of echo, and the presence of any interfering magnetic fields. It may cause disastrous complications sometimes, especially if the patient is having a pacemaker, a cardiac pacemaker, if he is having an intracerebral, intravascular coil, or if he's placing a cochlear implant, for example. For most of these patients, MRI is contraindicated, and CT scan with contrast or CT myelography is better advised. Some patients with cardiac pacemakers may have their heart rate fixed on the pacemaker before going into the MRI. So when to order an MRI, when you suspect or need to confirm degenerative disc disease, if you have spinal trauma, if there is motor or sensory deficient in a patient with spondylosis or with canal stenosis, if you suspect spinal infection, if you have an occult osteoporotic fracture and you need to study if it's an acute fracture or subacute or chronic fracture according to the bone marrow edema, and if you suspect the presence of spinal tumors and to detect the exact extension of such lesions within the vertebral column and around the vertebral column and within the vertebral canal. As I said, the T1, the most common sequences are the T1 and the T2 weighted images. Usually the TR, which is the time of repetition, is around 200 milliseconds, and the time of echo is around 30 milliseconds. You don't have to study these numbers, but this is just to demonstrate that there is a difference between how to obtain a T1 image and a T2 image. These numbers you can see written on the corner of each box of images on the MRI film. Then the proton density weighted images like the STIR, which is fat suppression, or the FLAIR, which is usually used for studying neural tissues like the brain, and also the spin echo technique. And there are other techniques which are usually not so needed in the study of most spinal disease cases. This is, for example, an MRI, a sagittal cut for an MRI of the lumbosacral spine. Here we can see that the disc material, the nucleus pulposus, is bright, okay, and the body of the vertebra is usually dark. Compared to this side, here we can see the same. The intervertebral disc nucleus pulposus is bright, and we can see here that the decrease of the brightness, or what we call the hypointense signal or decreased brightness, denotes that there is a decrease in the water content of the intervertebral disc in L3-4 and L4-5 and L5-S1 compared to the other upper levels. This, for example, is a T2 weighted image. And when you look here, you can see that this image is a special gradient, which is some kind different from T1 and T2, but I just want to compare the appearance of the intervertebral disc, the normally hydrated, intact, non-degenerated intervertebral disc, compared to the L4-5, L5-S1, and L3-4 here on the right side image, where the disc is degenerated with decreased water content, and posteriorly the disc annulus is usually bulging posteriorly into the vertebral canal. T1 weighted images are usually show high signal intensity for tissues with higher fat content. They show lower signal intensity for tissues with higher water content. They show iso-intense picture or appearance for muscular tissues, which means they appear grayish to some extent. And gadolinium enhancement is obtained usually over this sequence. The gadolinium enhancement, where you inject intravenous dye, which is called gadolinium, and you take the picture over the T1 weighted image. As regards T2 weighted images, usually it shows high signal intensity for water content. That's a brighter or more bright appearance. and it shows a lower signal intensity for fat content, which means a darker appearance. ISO intense, like the T1 images, ISO intense appearance for muscular tissues, grayish to some extent, and usually the fat suppression images or the stare images are obtained over the T2 sequences. The gadolinium enhancement or the contrast images, usually if a tissue takes the dye, which means that it appears brighter or hyper intense on the T1 weighted image after giving IV gadolinium, it usually denotes that this tissue is a viable tissue. It is a vascular tissue. It is a living tissue. It means it has a blood supply. For example, this appears in abscess walls and infected and uninfected granulation tissues, alive, non-necrotic tumor tissues, and inflamed tissues. Of course, if you look at in the gadolinium enhancement sequence or the contrast sequence, if you look at the lumen of the abscess or the central area of the abscess, usually it will be dark, not taking the gadolinium, meaning there is necrotic tissue and non-viable tissues. If you look at the central area of a tumor tissue where it is necrotic, not taking the gadolinium enhancement, it means this area is necrotic and non-viable. Then the stare images, which is the fat suppression sequence, it shows areas of increased water content, usually against a dark contrast of fatty tissue. That's why it is called a fat suppression technique, because it makes fatty tissues very dark so that you can compare edematous tissues to fatty tissues. This appears into fractures, in bone marrow fractures, or vertebral body occult, non-displaced or non-compressed, non-deformed fractures, and also in tumor tissues, it can appear with a higher signal intensity due to its higher water content. Then we can go for some examples here in the MRI. These are sagittal. This central picture is a sagittal T2 image, T2 weighted image. As you can see, the CSF here appears bright or hyper intense on this picture. So it's two pictures. Remember, water-rich tissues, H2O-rich tissues will be brighter on T2 images. Here we can see that there is subluxation of C4 over C5 with posterior annular rupture and disc prolapse, elevation of the PLL, posterior longitudinal ligament, and compression of the spinal cord within the vertebral or the spinal canal. In addition, you can see the signs of edema. Since most of the spinal cord is nervous tissues, or all of it is nervous tissues, it is covered with myelin, have high content of myelin, which is actually a fatty tissue, so it should be darker on T2 images as it appears here. So when you find a high signal intensity or a bright intensity within the cord, this means there is intra-cord edema in acute traumatic cases. If it's a chronic case like cervical spondylosis or cervical stenosis, it is named myelomalacia or cord malacia. Here also, as it appears that this is a traumatic case, you can see here the interspinous ligament and the supraspinous ligament called the ligamentum nuchae in the cervical spine, where it is disrupted and replaced by edema. Here we can see that this is a 3-column injury. The anterior, middle, and the posterior columns are disrupted, denoting that this is a cervical unstable injury. If you look at this yellow arrow, you can see this cut is taken into not in the midline plane, but in the paramedian plane, where you can see that these are normal facet joints, normally opposed and normally located. But if you look at here, you will find that this facet joint is purged and locked and subluxed or dislocated from the actual position. So this is the paramedian sections. And if you look up there, you can see that this is the lateral mass of C1. And you can see here that this is the groove for the vertebral artery transverse from the posterior over the posterior arch of the atlas. You can sometimes differentiate also in the MRI between hemorrhagic and non-hemorrhagic cord injury. For example, in this injury, in this type of injury, you can see that the central area of the cord is bright on the T2 image. As we said, this is the CSF bright, so this is a T2 weighted image or sequence, and you can see the cord edema as it is an acute injury with disruption also of the posterior ligamentous structures due to trauma, and disruption also of the posterior annulus of the intervertebral disc. On the other hand, this is a non-hemorrhagic injury, but if you can see a dark signal intensity within the cord, which is actually edematous throughout this area, this means that this is hemosiderin particles as seen in the MRI sequence. Also, it is a T2 sequence. As you can see, the CSF here is bright. As we said, H2O is bright. Then this is a T2 weighted sequence. And this also is a traumatic injury. You can see here there's brighter signal intensity or hyper intense signal into the vertebral body in these two adjacent levels compared to the upper levels, which are normal, but these are denoting the presence of fracture and bone marrow edema, disruption of the posterior annulus, and elevation of the PLL, and compression of the cord with hemorrhagic injury of the spinal cord. We can see also in the MRI signs of stenosis, cord compression or cord edema, and as we can see, some kinds of hyperextension injuries. In the previous two injuries, this is a kind of flexion injury, of hyperflexion injury with damage and disruption of the posterior ligament complex. Here, you can see that the posterior ligament complex and the posterior neural arches are intact, but the disruption is mainly anterior, where the intervertebral disc has been disrupted anteriorly. The annulus anteriorly is disrupted together with the anterior longitudinal ligament. Okay, and the presence also of stenotic canal due to the buccal ligamentum flavum posteriorly and the buccal or the prolapsed posterior annulus compressing further the cord with secondary cord edema or cord malacia, whether present due to the actually existing canal stenosing or exaggerated and accentuated by the super added hyperextension injury, like a whiplash injury. As we know, it's usually a hyperextension injury where the cord is pinched or receives a pincer effect between the posterior ligamentum flavum and the posterior aspect of the disc. طيب دكتور فوزي، انا هطفي الويب كام عشان turn off the web cam عشان النتورك كونكشن is slow. ها
اوكي ماشي الحال يعني.
ماشي. Okay, so let's see this image in the cervical spine. Which sequence is this? Is this T2 or T1? As I said, the CSF, which has high water content, is bright, so this is a T2, hyper intense signal of the CSF. And as you see, the fatty cord or the myelin in the cord shows that this is the cord in the T2 image. Which cuts are these? This is a sagittal cut, usually a mid-sagittal cut with a pre-cord space and post-cord space, clearly denoting that there is no cord compression, but still the cervical spine seems to be straight, denoting there is a cervical muscle spasm. As regards the axial cuts, you can see that this is the cord. These are the nerve roots. This is the CSF around the cord. And here you can see this is the foramen transversarium, okay, showing the vertebral artery. Of course, if we are at the level of the C7, there is no vertebral artery, only vertebral vein and accessory vertebral artery possible. And here you can see these are the carotid vessels, vertebral arteries in the foramen transversarium, and this is the foramen where the nerve root passes outward to form the brachial plexus. This is the vertebral body, the spinal canal, the lateral masses, the laminae, and the spinal process. In cervical spondylosis, what can we see? When you see the CSF as bright as this, so this is mostly a T2 weighted image. But when you see the vertebral bodies so dark like this, so this is mostly a fat suppression image or a stir image, where the fat marrow content is being suppressed and appears so dark so that you can pick up or see and this is 5-6 cervical level, where here you can see that there is a large disc prolapse compressing the spinal cord and causing canal stenosis and mostly causing neural deficit. And in addition, you can see that there are anterior osteophytes, and of course, there's a loss of the disc space height compared to the normal lower levels. And when you come to the axial cuts, you should see that this is the vertebral body. And if you see that there is a line of demarcation, two intensities, the annulus fibrosus, then the brighter nucleus pulposus in the center. Then you can see the prolapsed disc more to the right side with narrowing compression of the cord and narrowing of the right-sided foramen with a slightly better or slightly wider left intervertebral foramen. Mostly this patient will be having symptoms in the form of right upper limb symptoms and upper motor neuron symptoms on both or on the right lower limb. In case of trauma, we can see here that you should look at these items, fulfill these items when you comment on cervical trauma MRI. First, the alignment of the vertebrae. Is there any translation, or is there any loss of lordosis? Is there a straight spine, kyphotic spine, any degree of subluxation of lysis? You should also comment on any disc fragments, like this one. You can see here that this is C2. You usually number your vertebrae from the axis or the C2, which is the largest vertebra. Then the next one is 3, C4, C5. Here you can see C3-4 disc with a large disc prolapse causing compression of the spinal cord. Okay. Any ligamentous injuries posteriorly, as we said in the first MRIs we saw. Here you can see disruption and edema replacing the normal the ligamentum flavum and interspinous ligament posteriorly, the posterior ligament complex. Then you comment on the cord pattern and integrity. Here we can see the cord coming from up, downward, from the medulla oblongata, downwards, then becomes replaced by a high signal intensity denoting marked cord edema. Okay. And then returns back to its normal texture and pattern. And you will test to also check for foraminal obstruction on the axial cut, as we just said in the previous two slides. Sometimes you may find anomalies in the spine that you can detect on MRI. For example, cord anomalies or vertebral anomalies or anomalies of alignment. Here we can see that this is C2. Okay, C2. Okay, and here you can see that the C1 posterior arch and the C1 anterior arch, and this is the os odontium, which is the separated non-fused odontoid process. So there is C1, C2 instability in the form of subluxation with compression of the cord and attenuation of the cord and cord malacia in this area as the cervical, craniocervical junction. Okay, and this is actually turns out to be that this is the disc between C2 and C3, and this is the C3 vertebral body, C4 vertebral body, C5 vertebral body, C6 and 7, showing that this is a failure of full segmentation between C6 and C7, and here there is a failure of full segmentation between C2 and C3 with subluxation of C1 over C2 as a result of failure of fusion of the tip of the odontoid process, what's called os odontium. So here you can detect some kind of abnormal alignment, sagittal malalignment or forward subluxation, and failure of normal vertebral segmentation between C2 and C3, and also between C6 and C7, and finally the compression of the cord here at the the craniocervical junction. As regards degenerative disc disease in the cervical region, this is an MRI showing this. There is first, when you look at the alignment, you will find that there is complete loss of the cervical lordosis. In addition, further there is C2, C3 subluxation, anterior subluxation with compression and attenuation of the cord, straightening of the subaxial spine, no lordosis at all, together with attenuation of the cord, and also there is a cord malacia sign, malacia cord here, opposite this lowest level. So here you comment on the alignment of the cervical spine, canal diameter, and cord intensity changes, and cord integrity. This is the same patient. You can see here the difference between the mid-sagittal picture. This is the mid-sagittal picture, where you can see the cord all through the picture or the image. And here, when you cannot see the cord in the same patient, so this is mostly a lateral gutter or a lateral sagittal cut taken before the level of the foramen. Usually, if you go downward, slightly down, you can see the pedicles here, proving that this is not a mid-sagittal plane, but rather a paralateral or a more lateral plane. Then the most important view to comment on the foramina is the axial view. Here you can see, as we said, this is the vertebral body. This is the ancovertebral joint. This is the intervertebral foramina where the nerve root exits. You have to detect or to look or to examine at the intervertebral foramina at least at two levels, two adjacent cuts, or two adjacent levels, because sometimes the patient is not well centered on the table, or the picture is slightly oblique, so you have to check for this slide and the one above and the one below to make sure that the foramen is intact or obstructed. Here you can see that the foramen is more or less clear, no compression on the exiting nerve roots, and on the other side, when you compare both to one another, this is markedly stenotic, mostly causing symptoms in the form of parathesia or weakness on the left side. Of course, when you look at the patient or the image in the axial cut, you are looking at the patient from the direction of his feet, as if you are standing at his feet and looking at the spine from below. So this is the right side, and this is the left side. And here you can see also the foramen transversarium and the vertebral artery, and here's the lateral masses and the lamina and the spinous process, and this is the ligamentum flavum. And this is, of course, the cord, cervical cord. Then we shift to the lumbar spine MRI. One of the common terms that you hear is the modic changes. Modic changes are usually changes that occurred in the end plates, usually two adjacent end plates occurring adjacent to the single disc. Okay, sometimes these modic changes can be mixed with infection, can be misdiagnosed as infection, or the contrary, infections diagnosed as modic changes. So let's go through the modic changes. This is type 1 modic changes, which is usually the first pathological change, which is usually an edema, usually will be bright signal intensity or hyper intense on T2. As you can see, the CSF is bright, and dark on T1. As you can see, the CSF is hypo intense or dark. So this is type 1 modic changes, which is usually end plate edema. Modic changes type 2, this is T2 image, and this is a T1 image. Here you can see in the lower level, L5S1, it is bright on the T2, denoting that there's still some kind of edema, but on the T1 image, it started to convert from dark or from hypo-intense to hyper-intense, meaning that it is converting from watery content to fatty content. This is type 2 or grade 2 modic changes, denoting that there is undergoing fatty change or fatty degeneration, which is the next step of the modic changes or of the degenerative changes. Then the last one is type 3, where this edema and fatty changes are replaced by fibrosis and bony sclerosis. It will be dark on both. The T is sclerotic or dark or hypointense on both of these levels, and here it is dark also at the T2 image, meaning that it has low water content and it has low fat content, denoting there is sclerotic or fibrotic changes at the end plates. And what confirms this, that this is a degenerative process, is that the disk space is narrowed compared to the other level, and the water content of the disk itself is much decreased compared to the other higher up normal levels. Next, we can look at MRI axial images to detect migrated disk prolapse. Here is a vertebral body, and when you find the vertebral body with one texture, meaning it does not have an annulus fibrosis and a nucleus pulposus delineation, it means that this cut is taken within the bone or within the bony end plate. And when you see a disc fragment like this opposite the bony end plate or opposite the vertebral body, it means that this fragment is prolapsed and migrated, means it is no more opposite the disk space. It has either migrated upwards or migrated downwards. We can see here also these two large muscles on both sides of the vertebra, which are the psoas major muscles, and here we can see the aorta on the left side and the inferior vena cava on the right side, meaning that this is mostly an L4 or L3 lumbar level. Here again, you can see the spinal canal, the laminae, and the spinous process. You cannot see the facet joints, meaning that you are not opposite the level of the intervertebral disc. Normally, the facet joints are located at the same level of the intervertebral disc. And here you can see the erector spinae muscle or bone on both sides. Then, next, you start noticing part of the facet joint. And here is the intervertebral foramen. And here is the exiting nerve root after it has passed out of the intervertebral foramen, going to the psoas muscle to share in the formation of the lumbar plexus. On the other side here, you cannot see good delineation like here. You cannot see the end plate osteophytes, or the root is inflamed from friction or compression, causing it to lose its line of demarcation like the other side. This of course, when you see the CSF like this in the lower lumbar levels, it is the right signal intensity or the high signal intensity, so it is mostly a T2 image. And here you can see the iliac crests, meaning that this is mostly an L5 lower end plate level. Then we shift to the other side, where you can see the CSF is no more bright, it is hypointense. This means that this is a T1 weighted image. And as we said, in the T1 weighted image, you can see more delineation of fatty tissues. That's why you can see here the fatty tissue planes within the muscles. In both images, you will see the muscles grayish, isointense, T1 and T2, T2 and T1. But on the T1 images, you will see the more delineation of the fatty tissue within the muscle or in the subcutaneous tissues. Here you'll find it more bright compared to the fatty tissue on the T2 image. Again, this is the intervertebral foramen, mostly clear. Here on the right side, you can see that something is not okay with the right intervertebral foramen. It is mostly a disc prolapse, or it could be sometimes this is the shadow of an inflamed, compressed nerve root. And as I said, when you cannot see a delineation between the annulus fibrosis and the nucleus pulposus, this means that this cut is into the vertebral end plate or the bony end plate rather than into the intervertebral disc. Here on the right side or on the left side, you can see that the canal diameter is much decreased compared to the right side. Here you can see the canal is much wider with mild stenosis of the intervertebral foramina. Here you can see the demarcated annulus fibrosus and the well-demarcated nucleus pulposus with an intact, non-fissured, non-prolapsed annulus fibrosus. This means that this cut is taken at the level, exactly at the level of the disc, mostly of disc L5S1, because this is the sacral ala, and this is the sacroiliac joint, and this is the iliac wing. So this is mostly an L5S1 intact disc, non-degenerated, fully intact disc. Again, this is the beginning of the facet joint, the spinal canal, the coda equina, the spinous process, and the laminae. On this side, you will find the canal markedly stenotic, whether this is a disc prolapse fragment or mostly it could be, since it is taking the same texture or pattern of the bony end plate, it is mostly an end plate osteophyte which is causing the stenosis, in addition to the triangular or trifoliate appearance of the spinal canal. So this is a marked spinal canal case, and this is a nearly normal spinal diameter canal. Here, same picture. Here you can, when you see the end plate, same texture, no demarcation between annulus and nucleus, but it is dark or hypointense intensity on the T2. It is mostly a severely degenerated disc, not an intact disc and not a cut through the vertebral bony end plate. It is mostly, when it's dark like this, dark and blackish, hypointense, but same texture, it is mostly a cut through a markedly degenerated disc, and you can see here that the foramina are closed and the canal diameter is much reduced, causing spinal canal stenosis. Again, the psoas muscles, psoas major muscles on both sides, and the aorta and the vena cava. As you can see, the aorta is on the left side and is more circular. The vena cava is usually slightly ovoid in shape in its cut section, and to the right side. Sometimes you can get a patient with a penetrating injury, a penetration like a gunshot injury or a stab injury, for example. Here you can see that there is some kind of track starting from posterior, going anteriorly till the vertebral body. Sometimes these cases you can find a disruption of the cord or the coda equina. Here the conus medullaris together with the coda equina destroyed with edema extending upwards and downwards. Okay, and on the axial cuts, this is the vertebral body. You can see here a collection within the muscles. Okay, of course, when you have a high thermal injury, like a gunshot injury or some kind of a severe penetrating injury, you usually don't see the clear anatomy of the posterior elements that you see in degenerative cases. Rather, you can see some destruction of the muscles, and you can see the track, sometimes the track of the bullet or the projectile. This is the same patient. Okay. This is the coronal cuffs, which are usually not of great value in the MRI of the spinal disease or spinal trauma. You can see here that these are the psoas major muscles on both sides. Okay. This is usually the liver on the right side. You will see the intervertebral discs. You will see breaks in the end plate. Which in traumatic cases will show intervertebral body edema, high signal intensity on T2, I mean. And on degenerative disease and chronic cases, you will see diminution or decreased water content in the form of hypointense signal in the intervertebral discs. As regards trauma and fractures in MRI, you can see here that this picture, which is a sagittal picture, T2 as it's obvious because the CSF is a bright signal intensity or hyper intense. Here you can see this is a kind of wedge, or actually a burst fracture involving the anterior column and the posterior column with a retropulsed fragment compressing and stretching the coda equina or the conus medullaris. It's especially important in these patients that you check for the posterior ligament complex integrity, because this injury, it can be classified on X-ray and CT as a wedge fracture or a simple wedge fracture. The CT may further tell you that it is a burst fracture because of the involvement of the posterior vertebral wall and the spinal canal. But the MRI, if it shows a posterior ligament complex disruption and edema, will change it into a flexion distraction injury, as you can see here. Of the benefits also of the MRI is that it can detect other occult level fractures. This fracture could not be noticed on X-ray or CT. This only could be diagnosed, which is usually needing intervention in the form of posterior instrumentation, reduction, and fixation. But if you decide to fix such fracture, you will have to apply screws in the proximal or the cranial level, maybe single or double levels, and you stop short of just another fracture which is not detected on the CT or on the X-ray. So one of the benefits of MRI is that it can detect occult injuries which are not apparent on CT or X-ray. This is a T2 image. CSF is bright, hyper intense. This is a T1 image. CSF is dark or hypo intense. And as you can see here, this is a body fracture. It is hypo intense because it is high water content on T1 image, and here is high water content in T2 image. This is the patient, the same CMCT. Okay. Of course, if you can see this CT before you do the MRI, you will say these are two levels of burst fractures. The MRI will rule out whether it is a flexion distraction injury or a burst, unstable burst, according to the posterior ligament complex integrity. And of course, you can see here that it is not apparent or very query that it is a fracture or not on the plain X-ray lateral view. What about axial MRI cuts? Usually, they are not of much benefit in the trauma series or in trauma patients. They are of more benefit in the degenerative or stenotic or lysis patients, where you can detect the foraminal stenosis and disc prolapse, and if there is any foraminal or extraforaminal disc prolapse in the degenerative cases or disc prolapse cases. Better is the CT scan in the traumatic cases to delineate the degree of vertebral destruction, the degree of canal stenosis or canal compromise, and the degree of the spreading and comminution of the vertebral body, and also of the posterior neural arch and the posterior column. As regards the coronal cuts, I just showed you from the previous slides coronal cuts in the anterior portion of the spine, the vertebral bodies and the intervertebral discs. Sometimes you find these cuts with the patient. Here, a cut is taken more posteriorly in the spinal canal itself, where you can see these are the pedicles, the right and the left pedicles. And here you can see the right kidney and the liver above, and the spleen and the stomach on the left side. The spleen, of course, here is posterior. More anterior will be the stomach. Then we come to the degenerative lumbar cases. As you can see here, this is a T2 weighted image with variable degrees of disc degeneration. These two levels are okay, normal and non-degenerated. Then L4-5 and L5-S1 are degenerated with decreased signal intensity or hypointensity with posterior osteophytes. Take care not to judge on the presence or absence of lysis or subluxation in the MRI, because usually the patient has been lying in the machine for 20 or 30 minutes at least. So any degree of lysis has been reduced, or for example, a third degree will be diagnosed as second or first degree. A first degree could be subtle and not even apparent on MRI. So don't judge on the degree of lysis or subluxation on the sagittal MRI, but rather do dynamic films X-rays or standing lateral view X-rays. So here we can see degeneration of the intervertebral disc with disc degeneration and bulging, okay, in the anterior aspect of the spinal canal with minimal coda equina compression. Here's another example of a huge disc prolapse. As you can see, elevation of the posterior continual ligament, and non-migrated prolapse disc marked large, huge disc in compromising the canal. This is the T2 image. This is the T1 image. Of course, it's better to be judged or diagnosed in the T2 image. And this is the picture we saw before. When you find the intervertebral disc fragment not opposite the intervertebral disc, but rather opposite the end plate or the vertebral body, it is mostly a migrated disc prolapse. This is an example of modic changes. This is a T2 image, bright signal intensity or high signal intensity, hyper intense on T2, meaning that it is a high water content. Dark on T1 confirms that it is higher water content. So this is a modic change type 1 with decreased signal intensity of the intervertebral disc or nucleus pulposus, lower water content, and decreased height. Of special importance in such cases when you find bone marrow edema on the end plate, that you rule out infection. You have to check for the intensity of the intervertebral disc, check clinically with the patient for signs and symptoms of inflammation, weight loss, anorexia, fever like this, and perform lab tests like inflammation markers to rule out the presence of infection. If you have the disc space itself, together with these modic changes, have the disc space showing higher signal intensity, meaning it is bright as upper levels and lower levels, it means that there is high possibility of this being a spondylodiscitis, a case of pyogenic infection of the spine. So take care in such cases with modic type 1 changes. Also in osteoporotic fractures, sometimes when you perform an X-ray or a CT for a patient with osteoporosis, with acute back pain, not responding to medications and analgesia and rest, you can be suspicious of a fracture. In such cases, you can perform an MRI. MRI will show the bone marrow edema on the T2 images, and of course the hypointense or the darker signal intensity on the T1 images. It can tell you also if this is a recent or an old fracture. Sometimes you can see multiple fractures in a patient with back pain, an osteoporotic patient with back pain, and you find one or more wedged vertebrae, and you cannot say whether these are new or old. This is, of course, on the X-ray, on the CT. If you perform the MRI and you find that there is no signal intensity like this, no hyper intense signal in the vertebral body, it is mostly an old healed fracture. So you don't have to care about it. You don't have to pay concern to this healed level, but rather to concentrate on the fresh ones showing bone marrow edema. And of course, if the patient is having canal compromise associated, it could be due to the degenerative disc disease or canal stenosis pre-existing, causing some radicular symptoms, which can be exaggerated sometimes by the fractures occurring in such patients. Then this is a very important example. This may be one of the last slides. When you see high signal intensity like this, as we see, this is a CSF, bright signal intensity, a hyper intense signal, meaning that this is a T2 weighted image. Then you look at the bone marrow edema here. So someone may say, so this is a modic type 1 change, but you should, as I said, you should consider the texture and the pattern of the intervertebral disc. Here, the intervertebral disc is not hypo-intense. It is not degenerated, but rather more bright than the more caudal and the more cranial levels. This means that there is some kind of infection here, and this is mostly not edema. This is mostly pus or suppurative material. So in such cases, you should consider the presence or absence of infection. Check for the lab markers or the inflammatory markers. Take good history from the patient to exclude the presence of infection or previous fever or previous kind of treatment for any infection somewhere else in the body. It could be a septic focus with secondary spread to the spine, for example. Here we can see also that this is the pedicle showing the bone marrow edema, and the whole body in the dorsal spine in erythematous, the lower level as well, and the destroyed, deformed shape of the intervertebral disc. And sometimes you can see also a paravertebral collection of high signal intensity, denoting the presence of fluid. If this patient takes a contrast enhancement, meaning IV gadolinium, and you notice that this whole tissue, of course, this is a usual or a traditional T2 weighted image, but if this is a contrast enhancement picture and the whole area is taking the dye, you should suspect the presence of a mass, a soft tissue mass, rather than an infection. If it's an infection, only the wall of the abscess or the wall of the collection will take the dye, and the lumen or the cavity will be dark or hypo-intense on the T2 image. This is the axial cut. Here you can see multiple loculi of micro abscesses within the vertebral body and a paravertebral collection on this side, retropleural on the left side and retropleural on the right side. This is not the normal retropleural or pleural space fluid collection. And vertebral body destruction with extension of the abscess to the epidural space and through the intervertebral foramen more on the left side. Here in the sagittal, parasagittal picture or cut, you can see that there is a collection here, fluid high signal intensity, T2, in T2 image, communicating through the intervertebral foramen, extending 2 levels higher up, and also possibly to the lower down levels. Same patient with complete destruction of the vertebral body, replacement by high signal intensity signal in the T2 image, showing the presence of an abscess or a fluid collection on both sides, with compromise of the vertebral canal and compression of the dorsal cord. This is the same patient in the T1 image. As you can see, this is the CSF here before the cord or in front of the cord, and here to the cord is hypo-intense or dark signal intensity, meaning this is a T1 image. So this does not show high signal intensity. It means it is not fatty tissue. It is water content, high water content tissue on the T1 image, showing a marked inflammatory reaction, whether to a tumor or an infection. And if you compare it to the T2, the previous slides, the T2 image, you could suspect more of an infection. If you are still in doubt, you perform a gadolinium enhancement or contrast enhancement, which is usually, as I said, performed on a T1 image. Here you will see if this was a tumor, if this were a tumor, it will take the dye, the contrast, and will become hyper intense and bright on the T1 weighted images. And by this we finish our presentation. Thank you for your attention, everyone.
Thank you, Dr. Ahmed, for your nice presentation. It is really a great one, covering cervical and lumbar spine pathology. May I ask you, Dr. Ahmed, can you highlight again the importance of a stair sequence in case of fractures and tumor?
Okay, the stair sequence, the concept behind the stair sequence is that you perform suppression of the fatty tissues. I will try bringing one of the pictures. Okay, so when you perform the stair sequence or the fat suppression sequence, you want to see the slightest grades of edema, of tissue edema. This can occur in the minor or subtle fractures, in infections, or in tumors. So, as this picture, you can see here that the texture of the vertebral body is severely dark, is markedly dark or severely hypointense. This means we all know that the vertebral body contains blood and contains marrow fat. So it is a mixture between water content and fat content. So it's normally, it should be like this. When you find it very dark like this or hypointense like this, it means that we have suppressed the fat. Still, we know that this is a T2 image because the CSF is bright here. So you suppress the fat so that the slightest grades or slightest degree of edema could appear on the image, and you can easily detect it. As I said, this is possible on the infections, tumors, and vertebral body fractures. Maybe you cannot differentiate between the three, but you will later differentiate by ordering a contrast enhancement film, which I said will be done over a T1 image to show if this tissue is a vascular tissue, is it a cavity, an abscess with enhancement only of the walls with the lumen being dark, or is it a soft tissue mass with enhancement of all the mass because all the mass is vascular.
Okay.
As you know, only the vascular tissue will get enhancement on gadolinium contrast images.
Okay. Professor Maziad, kindly unmute yourself and deliver your comment. Professor Maziad. Professor Maziad, kindly unmute yourself and deliver your comment. Till Professor Maziad be ready, there is a question regarding the sedimentation sign in MRI to diagnose spinal canal stenosis. It said that it has sensitivity up to 90% or 94%, and the specificity is very high as well. Are you aware with this sign?
No, actually, I don't depend on this in diagnosis of a case of infection or anything.
Sedimentation sign, and it is a question from one of our attendees. Sedimentation sign is a criteria designed by some colleagues, and they stated that if the patient has short standing time and short walking distance, less than 200 meters, when you allow the patient to lie in the MRI machine and at acquisition of the imaging, when you see in the axial cut that the nerve roots are posteriorly settled, that means there is no spinal canal stenosis. When the nerve roots, the coda equina inside the dural sac is still floating in the fluids in the dural sac and not sedimented posteriorly, this means it is positive sedimentation sign that there is a stenosis. Of course, it's debatable, but it is one of the...
Actually, I think yeah, this is a good point. But I think when you are going to decide whether the patient will need injection or medical treatment or surgery, it usually, even if you are having severe stenosis sign on the MRI, it will depend also mainly on the symptoms of the patient, if there is neurodeficit or not, his walking distance. So I think that the first part is okay. Of course, this is a diagnostic tool that we should not neglect or consider, but I think it would be beneficial more in cases where there is mild to moderate stenosis on the MRI, when you are not sure that this is the main cause of the patient's symptoms.
Okay, so we don't have more questions, so I can start my presentation. Can you see it, Ahmed? Can you see
yes, I can see. Yes, I can see it. I can see it.
Okay, so it will be short presentation discussing with you the degenerative disc disease, lumbar degenerative disc disease, and different ways to manage lumbar degenerative disc disease. First of all, if this is knee with varus deformity and subchondral sclerosis, you can see here, and narrow joint space, and the new bone formation and the osteophytes are formed. So it is quite clear that this knee is arthritic. We can have the same in the spine. If we can see the disc here and the disc here, it is collapsed disc. We have some osteophytes and we have the narrow foramen, as we can see here as well at this level L5S1. We can see some degeneration, subchondral sclerosis, and it changes, degenerative changes in the sacroiliac joint as well. So as the degenerative cascade can be anticipated in the big joints like the knee or the hip, it can be anticipated as well in the spine, and it can cause back pain. And before proceeding further in this presentation, I'd like to highlight something When you have osteophytes and lipping at the anterior vertebral body like this, when it is flat, as I show you by the cursor like this, flat osteophytes, it may be an indication of instability. If the osteophytes is 45-degree angled, it is the osteophytes of the degeneration. If the osteophytes is perpendicular and nearly want to touch the osteophytes from the other vertebrae, like as I show you by the cursor, it is osteophytes or syndesmophytes for ankylosing spondylitis. This is another plain X-ray lumbosacral spine showing degenerative changes in the sacroiliac joint and degenerative changes here in the posterior facets as well. And if we can see here, there is grade 1 spondylolysis, and we can here see some clefts as well. And these clefts here can be an indication for that there is complete degeneration of the disc with nitrogen formation, and as we can see some gases here in the L4-5 disc. Back pain among the population is very common, and almost 80% of the population can come and visit you in the outpatient clinic complaining from back pain. And even we can call it the normal back pain. But when it is become disabling back pain, it is really attracts the doctor attention. When it doesn't resolve with the non-steroidal anti-inflammatory, or when it increases at night, you must think in other causes of back pain, not only degenerative, but also something like infection or tumors. And of course, the management of back pain starts from conservative till fusion and surgeries. And you need to know that in one of the countries like USA, you can have something like 2,000 fusions per year. Let us discuss some pathophysiology of degenerative disc disease.
Dr. Fawzi, I think Dr. Saad needed to ask about something. I want just to check if they are hearing us properly. Dr. Saad?
Dr. Saad?
Are they hearing us properly? Because he wanted to say something.
Dr. Saad?
Okay. So proceed, Dr. Fawzi. Okay.
Yes.
Okay. Let us discuss some pathophysiology regarding the disc and disc degeneration. This is a healthy disc. This is diagram A, showing that the nucleus pulposus is healthy, contain proper water content, and most of the coming loads over the anterior column come through the nucleus pulposus, and it can carry loads. With aging process and with degeneration, you can have degenerative cascade in the nucleus pulposus, and here the weight is not transmitted through the nucleus pulposus, the weight is transmitted through the annulus fibrosus. And the annulus is actually not designed and not created to withstand these maximum loads. This creates annular tears. And if we can see here, the annular tear, which is sustained due to the abnormal loads which can be anticipated on the annulus fibrosus, the nucleus pulposus start to migrate through these tears, creating fibrovascular tissue with nociceptors, creating pain. And this is one of the causes of pain that can be anticipated due to degenerative cascade. You know that we have a functional spine unit, which is composed of the vertebra above, vertebra below, the disc in between, with the facets posteriorly, and the ligaments, which is covering the supraspinous, interspinous, intertransverse, and fascic capsule, everything, and the anterior longitudinal ligament, posterior longitudinal ligament. This is the functional spine unit. So when we are speaking about degenerative cascade, we need to highlight the changes inside the disc and the changes in the facets as well. Inside the disc, as we said, abnormal loads anticipated on the annular that create annular tears, which can be defined as dysfunctional state. And afterwards, the nuclear pulposus start to go through these tears, which lead to nuclear peripheralization, and hence we can have herniation of the nucleus pulposus with the symptoms of with the symptoms of herniated nucleus pulposus, radicular pain, which can be anticipated from the glutei down to the feet crossing the knee. And after disc peripheralization, the immune system start to resorb it and help to remove this disc material. So we have disc resorption and decrease the disc height. This create instability state in the functional spine unit. And of course, the body tried to defend itself by forming the osteophytes and the new bone, which create fixed deformity or stenosis according to the presence of osteophytes. Regarding the facets joint posteriorly, you can have.
Dr. Fawzi, can you please repeat the previous minute, because there was interruption in the sound, in the audio.
Okay.
Let's start from the beginning of this slide.
Okay, it is actually, I will repeat it because it is important slides that can describe the degenerative cascade, which can be anticipated in the functional spine unit, starting from the disc, which lead to decrease in the water content and the proteoglycans inside the nucleus pulposus. This can create abnormal loads and stresses over the annulus, creating tear inside the annulus, leads to nuclear peripheralization, and this is a dysfunction state. Here the patient can start by complaining from back pain, followed by radicular pain when the nucleus pulposus start to peripheralize outside and compressing the nerve root and cause some chemical irritation to the nerve root. This followed by disc resorption due to the immune system. The disc is one of the biggest sequestrated antigens inside our body, and when it is peripheralized and the body try to attack it to cause resorption of this abnormal sequestrated antigen, and the disc height, of course, we can lose it, and this stage can be called the instability state. And of course, the body will try to defend itself by forming osteophytes, and according to the presence of osteophytes, we can have some stenosis. For example, if the osteophytes can be anticipated in the lower posterior facets, it can cause central canal stenosis. If the osteophytes anticipated in the superior facets, for example, it can lead to foraminal stenosis. If the osteophytes are anterior, it can progress and cause some anterior osteophytes. Regarding the changes in the facet joints, start by synovial reaction, synovial inflammatory cascade. This is followed by cartilaginous destruction, and of course, with the instability state, we have some sort of laxity in the capsule posteriorly, and with instability, we'll have subluxation in the facet. And here we can see in the MRI sometimes this facet effusion sign, which indicates the instability state. With enlargement of the facet, this here the body as well try to defend himself by enlarging the facet, trying to stabilizing the situation by forming facet osteophytes as well. Regarding the biomechanics and the motion segment, we have instantaneous center of rotation. That means we have محور دوران الفانكشنال spine unit is لحظي في كل لحظة مختلف, instantaneous center of rotation. And in healthy disc, it is present in the posterior third of the disc. But with degenerative cascade, it progressed, and we can see here the centroids start to go outside the disc itself by go inside the vertebral body above and below, and then we can find different changes till the end as all the instantaneous centers of rotation become a little bit limited. There is no much motion and become most of them inside the vertebral body itself, and we lost the motion at the disc level. Regarding the symptoms, as we said in the previous slide, it depends on the state. If it is early, it can be presented by back pain. Late, it will be presented later, will be presented with radicular pain with herniation of the nucleus pulposus, and later will be there is mechanical back pain with instability, and at later stages there will be deformity like degenerative scoliosis as well. And each stage from these we'll discuss later in next presentations and next webinars, inshallah. How we manage the degenerative prolapsed disc after failure, of course, of conservative treatment. And I'd like to highlight something. Conservative treatment is mainly medical treatment and physiotherapy. Medical treatment, as we know, non-steroidal, muscle relaxant, nerve tonics. Physiotherapy, when the patient has centralization of the symptoms, when the patient has back pain. I can say to you, when the patient is complaint is only radicular pain, there is no rule for the physiotherapy. I believe that, because sometimes if you ask the patient to do some exercises, it can increase the symptoms of the patient. If the patient has prolapsed disc with failure of conservative management, maybe we think in surgical treatment like simple disc excision through fenestration, or laminotomy, or partial laminectomy, or total laminectomy, or our indication for management of a patient with prolapsed disc with severe radicular pain, with muscle weakness after failure of conservative treatment for 6 months at least. We can replace the disc material. Yes, we can replace it or do fusion. This is a patient presented to me after having here laminectomy. You can see here, this is here the spinous process, this is the lamina, this is the pedicle, this is the vertebral body, this is the inferior facet, and this is the superior facet here. This patient underwent the complete laminectomy for L4 vertebral body and L3 vertebral body and part of L5 as well, and he presented to me with post-laminectomy retrolysis and instability. And I can explain that the surgeon really affect the facet stability, and that is cause of post-laminectomy instability and a cause of flat back syndrome. And of course, this patient will be a candidate for fusion. This is another case presented to me after laminectomy with a spondylolysis and the gas sign here, complete degeneration of the disc at L5S1 with narrow foramen here, and the patient, of course, complaining from mechanical back pain due to the instability, beside radicular pain as well due to stenosis and affection of the levels. And while examining these patients, please don't neglect the sacroiliac joint, and you need to highlight that may the patient complaint regarding the back pain and leg pain improve greatly after your surgery, but highlight that sometimes of these patients, especially female patients, short stature, diabetics, are complain from sacroiliac joint pain after doing these surgeries. And this is my experience regarding post-surgical sacroiliac joint pain. Regarding the fusion, it has been considered as a gold standard surgery for disabling back pain after failure of conservative management and local injection as well. There is posterolateral fusion. We put the screws as the rods, and we put the bone graft posterolateral here. And then the scientists start to say that the better is to achieve fusion by doing anterior interbody cages. It is under compression. Cancellous bone anteriorly can achieve better fusion. But I'd like to say something. Keep in mind that there is no stand-alone cages, because there is a zone in motion segment inflection extension called the neutral zone, and the stand-alone cages are unstable in the neutral zone, and you may have dislodgement of these cages. So most of us do instrumented fusion by pedicular screws and interbody cages as well, with different technique, either PLEF, posterior lumbar interbody fusion, or TLEF. But spinal fusion, it restricts the motion. It increases the stresses on the adjacent level and may lead to flat back syndrome if you didn't consider the spinopelvic parameters. And of course, the sacroiliac joint pain suffered from multiple stresses, and you can have graft site morbidity if you harvesting iliac crest bone graft, and pseudoarthrosis can be anticipated in some cases. This is a case, for example, presented to our clinic with pseudoarthrosis at L5-S1, loosening of the screws here, and the flat pack. So this case needs revision as well. Another case with adjacent level pathology, the surgeon at the index surgery didn't respect the spinopelvic parameters, and we can see here that distribution of lumbar lordosis is not the ideal. At L4-5-S1 is 2/3 of the lumbar lordosis, so we can anticipate here adjacent level pathology with osteophytes trying to stabilize the situation and the gas sign inside. Of course, the solution is to go one level up and try to restore the spinopelvic parameters according to the pelvic incidence and the gap analysis of these patients. Not only the effect of fusion that there is limited mobility and increase the stresses around the adjacent level, but also if you use conventional technique instead of minimally invasive technique, you can have what is called the fusion disease. There is fibrosis and adhesions in the back muscles, which can be highlighted in the MRI postoperative, and even there are some studies which can confirm that there is the extensor muscles of the back is weaker by 50% in relation with the preoperative. So is there something new? It is not actually new. It was a long time ago. This was actually my MD thesis in 2006, 14 years ago. It was the spine arthroplasty, total disc prosthesis. It actually has the theory that it can restore the motion and maintain the motion, and by this means we can decrease the stresses over the adjacent level, preventing the adjacent level pathology. So if we have the baseline is the conservative management, and if we have the top stage here is the fusion, all these steps we can use here: physiotherapy, we can use injections, we can use endoscopic techniques, we can use spine arthroplasty. So it is one of the steps in our managing strategy. Due to the abnormal biomechanics, especially at L5-S1 and in the lumbar spine, this is the functional spine unit, vertebra above, vertebra below disc, the facets posterior, and the ligaments, which is strengthens the stability of the functional spine unit. Due to the shearing forces at L5-S1 and the flexion, extension, and the actual motion in the spine is called coupling motion. That means it occurs in three planes, not only in one plane. Each motion can be anticipated in different planes. Spine arthroplasty are two types: are either partial replacement after removal of disc. You can put prosthetic disc nucleus, BDN solo, which is a gel covered by this polyethylene jacket, which can be anticipated, but a lot of failure can be anticipated and it can be proved in the literature. And total disc replacement, like the ProDisc here, which is a keeled prosthesis. The history of spine arthroplasty started since 1950 by the primitive artificial disc, which is tested in cadavers. This is followed by a Fernstrom pole, which is applied in some patients, 250 patients, and John Kennedy, the president of USA, was one of these patients. They applied this pole, Fernstrom pole, inside his disc. And in 1970s, multi-component device are anticipated, like this chamber filled fluid with end plate up and below, try to mimic the normal anatomy or normal appearance of the disc. And this is followed by the actually game changer, the ProDisc and the SP Charité. SP Charité was invented in Charité Hospital in Berlin by Professor Schellnack and Putner Jans, and Thierry Marny in France, the first one to introduce the ProDisc. And I visited Thierry Marny maybe 4 years ago, and he still now implant every day he implant many ProDisc till now. So this is the presentation for today. I'd like to hear from you any questions, and we are happy to answer your questions, inquiries, and to have your comments as well. So,
thank you, Dr. Fawzi. Thank you, Dr. Fawzi, for the presentation. Does anybody has any questions?
I think Dr. Amin Hanin has here, is the absence of the sedimentation sign sufficient to make the diagnosis of central spinal canal? I don't think so, actually, because you cannot rely on the sedimentation sign as a diagnosis. You rely mainly on the clinical signs and symptoms, because, for example, if the patient has arachnoiditis, or if the patient has some problems that can cause the root to be amalgamated, it can affect the sedimentation sign. So I don't believe that. Regarding what about the interspinous devices and dynamic stabilization? Good question, Dr. Amin. Regarding the dynamic stabilizers, I'd like to tell you, patient selection is the key of success. Patient selection is the key of success in any spine surgery. I have experience with the interspinous dynamic stabilizers in some cases, like cases with kissing spine, like cases with hyperlordotic or hyperlordotic cases, in cases with spondylolisthesis, but with lordosis as well at this level, and the patient only complain from something like mechanical or radicular back pain. In these cases, you can have good results with interspinous spacers. There are different types. Types can be introduced percutaneously, and types can be introduced by small opening. But of course, the patient selection is very important. But I'd like to highlight something: to use it in multiple levels a little bit not favorable. To use it in every patient with spinal canal stenosis not favorable, because it creates a little bit element of kyphosis. So you need the patient to have lordosis. It will be improve the symptoms as well. And of course, the stenosis must be not severe stenosis, something like, we can say, mechanical.
Can I comment?
Yes, sure. Mechanical stenosis.
Regarding the interspinous spacers, I think when you perform these, you usually don't have severe kind of instability or a severe kind of stenosis to push you or to convince you to perform surgery in the form of decompression or decompression fusion. So I think most of us, or those who performed interspinal stabilization techniques, have variable results, and the literature shows variable results with failures and success, with different patients and different ages and different indications. I think in this group of patients, the best thing is to try selective root blocks or epidural steroid injections, whether caudal epidural or interlaminar, combined with selective transforaminal injections. I think it would be a better or a wiser decision if you don't have a frank prolapse disc, for example, if you don't have a significant physical obstruction within the canal or within a foramen. So still, if someone has good results with interspinal spacers, his practice is doing well with this, he can proceed for them. If he's not well practiced or he has bad experience with them, he should try intervertebral foramen injections or epidural injections until the patient needs frank surgery. So this will solve the problem.
Completely agree with you, Dr. Ahmed, that I will consider actually the injection is a state before doing any surgical intervention. I will consider conservative management in the form of medical treatment and physiotherapy, and this is followed by injections. Then you can choose a surgical procedure. Dr. Ahmed, can you comment about a question from our dear friend Dr. Ahmed Izzat regarding when to say that there is failure in conservative management?
In degenerative disc disease?
Yes.
Okay, first, if the patient, I will consider that the patient is coming without neural deficit, without significant disability at the beginning, you should start your medical treatment. You should add physical treatment if you think it would act to the improvement of the patient. I think progression of the symptoms while the patient is on treatment is an indication of failure. The occurrence of a neural deficit or increase in paresthesia and symptoms are indications of failure of treatment. The occurrence of side effects of my medications or side effects from the physiotherapy is considered a failure of conservative treatment. Of course, if the patient is coming from the beginning with a neural deficit, I mean weakness, some grade of weakness, or a severe grade of stenosis, which is non-debatable or is no more controversial, this would not push me towards conservative treatment from the start. On the contrary, I would go for surgical treatment. And the points or the criteria I mentioned for failure, of course, then if it occurs while I'm doing conservative treatment, should be a significant sign of, you may say, a sign that you should shift your treatment towards surgical or some kind of interventional treatment.
Okay, so to conclude, if there is the deterioration of the signs and symptoms or any complication from the kind of treatment, right?
Yes, and if the patient, let's say the patient is improving and he is feeling that he is improving on a short pace, for example, after 2 to 3 weeks, there is, let's say, 20 to 40% improvement, I would continue conservative treatment. If it's after 2 to 3 weeks, no improvement at all, I think this is considered failure of conservative treatment.
Okay.
The would be an indication of failure if the patient doesn't improve much. But if he spends 3 weeks, for example, without any improvement, I think this is an indication of failure of medical treatment or conservative treatment.
Okay.
Can I comment?
Yes, sure.
Yes. Thank you, Dr. Morsi, and thank you, Dr. Fawzi. This was a very nice presentation from both of you. From my point of view, we have to continue conservative medications at least for 4 to 6 weeks, because some of our patients do respond after 4 to 6 weeks. If failure of medication happens after 4 to 6 weeks, then this is an indication for surgery. If, as Dr. Morsi said, everything is okay, there's no neurological deficit and no sphincteric problem. Otherwise, we have to continue for 4 to 6 weeks.
Okay.
Okay. So Dr. Saad, you consider that the patient, even if the patient does not show any sign of improvement up to 4 weeks, we can continue further 2 weeks. You are behind this concept, right?
Yes, unless he develops any deterioration or any problem from the medication.
Yes, I wouldn't object for this. I wouldn't object for this, especially if the patient's symptoms are, for example, moderate, and he can still go by doing most of his activities, and he's not crippled or disabled by this pain.
Yes, sure. And if he does respond for the medication, and after stopping the medication after 4 to 6 weeks, he returns to the bad story again, then this is another indication for going to surgery again.
Okay, just let's talk about this point, because sometimes if the patient improves, for example, let's say, according to your concept, and the patient feeling himself, he tells you, I'm feeling that I'm 60 to 70% increased, but when I stop the medications, I have the symptoms back again. So can we keep this patient? Some patients may tell you, keep me on the medications. It's okay for me. I can do whatever I need on the medications. I don't want to do surgery. Is this accepted? That we keep the patient, not of course on the full dose. Would you keep him on, you try to decrease the dose and keep him on neurotonics and anti-inflammatory and anti-edema medications, neurotonics? Would you accept this?
I would go for advise him for surgery unless he refuses that, and this is his own option. but I would recommend surgery for him if he returns to symptoms again.
Okay, so you would tell him it's okay, you can keep this, but I advise you that you shouldn't be kept on medications for a long time. You
Yes,
should
sure.
you should reduce medications as much as possible, especially many of these patients are elderly or old age and having other comorbidities like hypertension, for example. So it's not advisable to take medications for pain for a long time. It's better to perform surgery if you don't need. This is a different story.
Sure.
Okay, I agree with you.
Great. May I ask you, Dr. Saad, that can single-level disc prolapse can cause foot drop? This is a question from our friend Ahmed Azzat.
Yes, if it is compressing the exiting nerve root, or if it's a traversing nerve root, and it's a huge one, yes, it can cause that.
Okay, sure. Regarding the gas sign, Dr. Morsi, is it a sign of disc degeneration or a sign of instability?
No, actually, it is a sign primarily of disc degeneration, of marked disc degeneration, what we call the vacuum sign or the gas sign. It is a sign of marked disc degeneration, which in turn could or could not be associated with instability. And of course, you can easily judge instability by doing dynamic films or lateral standing films to see if there's any translation within the spine or loss of alignment. Of course, most of these discs which show a vacuum sign or the black disc sign usually will have a markedly diminuted disc height. It will not retain the normal disc height. So this may go also with the concept of some element of instability. Maybe it's not such an overt or obvious instability, but there's some degree of spinal instability in this markedly degenerated level. But of course, it may not be an indication for surgical fusion or surgical fixation.
Okay, so when to stop conservative management by using non-steroidal and anti-inflammatory drugs or painkillers? For how long you can use it? Till the patient complain from gastritis, till the patient liver enzymes start to elevated or the kidney enzymes. For how long you can use the non-steroidal anti-inflammatory drugs? This is a question from Gordon.
Okay, usually I would start for the full dose for 3 to 4 weeks max, together with gastroprotective, whether H2 blockers. I prefer H2 blockers rather than PPIs. Then I should decrease to half the dose. Okay, so let's say 4 to 6 the dose for another 4 to 6. Then I ask for paracetamol and to keep these non-steroidals only for the use as he's in severe pain or having muscle spasm or something like this, especially in high-risk patients. High-risk patients, I mean patients who are prone to get gastric ulcerations with a previous history, patients who are hypertensive with possibility of non-steroidals causing elevation of high blood pressure, patients who are diabetics because they are predisposed to renal to nephropathy from diabetes, especially if they are long-standing diabetic patients. So these patients are at high risk to get injured, to get renal injury from non-steroidals, especially in low doses.
Okay.
So I would keep it full dose for 4 to 6 weeks, then half the dose for another 4 to 6 weeks max, protected by H2 blockers like famotidine.
Okay. Dr. Rehab Hosni.
Together with the other medications like gabapentins or neurotonics or alpha-lipoic acid, cytosine are key to take for longer times, no problem. But the main problem is with non-steroidals.
Okay, Dr. Rehab Hosni, would you like to comment?
Good evening, Dr. Muhammad. Thank you for this nice presentation, and Dr. Ahmed Morsi, thank you so much. I just have two comments. The use of McKenzie test in deciding how long we can use conservative treatment and when to shift to surgery. The McKenzie test is very useful in cases of disc prolapse. If the pain is centralizing on McKenzie test, then this patient is hopeful for conservative treatment. If in McKenzie test there is peripheralization, I mean pain, radicular pain or pain in the legs, then this is not a good sign, and this patient may not respond to conservative treatment. And if he does not respond in a short period of time, then you may have to shift to surgical treatment. The other thing, in cases of spinal canal stenosis, there is a useful MRI view, which is the coronal oblique. This gives a very good view of the ligamentum flavum and how much there is actually stenosis in the central canal. These are just my two comments.
Okay, thank you, Dr. Ahab. Very nice comments adding to the presentation. Thank you very much. May I ask you, Dr. Ahmed, does CT scan has a role in degenerative spine?
CT scan in degenerative spine. Okay, let's say that sometimes the offending agent or the physical cause of the root impingement or root compression or foraminal compression is not actually a soft disc. It may be an end plate osteophytes. As one of the axial pictures I showed on MRI, it could be an osteophyte from the end plate. This, of course, would be easily missed if we don't perform CT scan. Also in patients with, and the disc itself, of course, if it's a long-standing disc, many times you can go for a large disc. You are so enthusiastic that you will get a large disc, but you get stuck with a ossified, calcified disc, where you can difficultly remove the disc, and you may end up injuring the dura or the nerve root. So it's important in long-standing disease and long-standing symptoms that you perform a CT scan to detect is there any ossification of the posterior annulus of the intervertebral disc. Also, in patients with revision surgery, it's mandatory that you perform CT scan first to know how much of the posterior elements have been removed to guide you while you are reaxing the spinal canal or the facet joints. This is very important, and because there's also sometimes, whether in revision cases or in primary cases, ossifications of the ligamentum flavum could be some kind of physical impingement or physical constriction of the foramina that may be cleared, that should be cleared during surgery. So it's important in some special cases to perform CT scan to rule out any possibly missable lesions.
Okay, great. Thank you, Dr. Ahmed. So we don't have more questions, we don't have more comments. So thank you, everybody, for your attendance. Thank you, Dr. Saad, for sharing your experience with us from Jordan. Thank you, Dr. Ahmed. And inshallah, be ready. Tomorrow we have Dr. Saad. Can you announce for your webinar tomorrow?
Yes, thank you, Dr. Fawzi. We have a webinar about innovations in spine surgery by Dr. Ihab Shiban from Germany, and we hope that you all can join and share our experience from your side to the new innovations in spine surgery. You're most welcome, and Dr. Fawzi will share you the registration form and the registration site for the login.
Inshallah. Thank you, Dr. Saad, for your efforts.
Thank you, Dr. Saad.
Thank you
all. You are brilliant.
Thank you. Thanks for the attendees. Thanks, Dr. Morsi. And inshallah, see you tomorrow with Dr. Saad. It will be at 6 p.m. Cairo time, inshallah. And stay tuned. Inshallah, there will be more coming webinars in the next week إن شاء الله. السلام عليكم ورحمة الله وبركاته. شكرا جزيلا.
عليكم السلام. تصبحوا على خير. السلام عليكم.